describing is not, iffy. And they didn't really clear all the way. And they have another seizure in the ED. So they're calling because this is status, and they've loaded the patient. And this is a high-level facility because they just recently got an EKG, so they're really, doing it, but that's about the level that they can do. They don't have EEG. And they're saying the guy's not clearing. So my question is, if I personally were loaded with Ativan, I don't think I would be very awake for quite a while. So ought I just say send the patient in? Because if they're not clearing, how do I know if they're not clearing because they're still subclinical? Or they just had a big slug of Ativan? How long can I wait before saying, okay, this guy isn't waking up because they may still be seizing? How does one handle that situation?
Yeah, that's a very excellent question. A situation we see quite often. So to answer that, after someone has convulsive seizure, they can be postictal as well. So are they not waking up because they just got Ativan and loaded with something? Are they postictal and sedated? Or are they a non-convulsive status epilepticus? So I think, we're looking for some sort of neurological recovery. After the convulsive seizures end, they may be very well out of it. But we're looking for, some sign that they're starting to wake up, they're starting to move. If you don't get any of that, it's hard to place a time duration on that, but I would probably start that process of looking into, how can we get them on EEG? Could it happen here, or should it be referred elsewhere for EEG monitoring? So kind of initiating that process earlier than later, because it all takes so much time. The patient that we saw, he had multiple portable EEGs until he could get to our facility with continuous monitoring. So just kind of starting that earlier. And if in the next hour or two, let's say the patient wakes up and is responding, then you can cancel the transfer, start him on medications, do the workup, and he may be able to go home. He or she may be able to go home, but at least you have that kind of transfer initiated and started. Great question.
So I'll do a online question, then we'll take Blake's question. I'm not sure if this is going to be for Susie or Liz. The question was use of Diamox in menstrual-related seizures. So
yeah, there's a catamenial.
Just pull the.
Yeah. And you can expand, but there's a catamenial tendency in some women. So as we go through our cycles, right, everything can be cyclical, even in men in epilepsy. There's lots of studies that show every 7 to 10 days we can have seizures recur, or every month or every 2 months. In women specifically, hormones play a big factor in that. And so actually during pregnancy, we get typically very steady hormones, and women tend to have less seizures. Or once we hit menopause, we can see a good positive change in that. In the catamenial population, we do have some targets. We do use Diamox at times. We also sometimes use hormonal therapy to help someone through those, to get a steady hormones throughout the month. And then also sometimes we use like a benzodiazepine around the time of their period. So if they've got very regular periods, they know they're a 28 cycle, then I'm having them start maybe day 26 a benzodiazepine for 5 days to see if we can get a little stretch through that period of time.
Yeah, we don't have much.
Blake?
Liz, can you tell us what the current approach is for an acute symptomatic seizure? Say someone comes in with an ICH, you discharge them on some sort of anti-seizure medication. What is your typical follow-up time? Are you repeating an EEG? Are you weaning them off? Are you keeping them on long-term? I know that there's always a lot of questions around discontinuation and how to manage that acute symptomatic seizure.
Yes, absolutely. So there's actually a very nice article on this, and a scale. I'm blanking on the name of the scale right now, but there's a study that there's a scale that you can kind of enter. There's 4 components of it. The patient, where the stroke occurred, if it touched the cortex or was it subcortical, their age, and different factors, and you kind of plug these numbers in, and it can give you actually a risk rating. And I'm blanking on this name. Maybe I can send it to Dr. Stevens later. But this scale can kind of gauge their risk of seizure recurrence down the line. So if I think the age is above 60, or the age cutoff is 60, if the stroke hits the cortex, if they check all these high risk boxes, you may want to, like when I see them in an outpatient setting, I kind of counsel them on the level of risk they have for seizure occurrence based on that. Maybe I'll think of the name while we're sitting here, but generally for acute symptomatic seizures, the hope and goal is that at least we can start weaning, and potentially if they're in that lower risk range of seizure recurrence, wean them off and try them off medications. Before I decide to do that, I usually get an EEG to see if any epileptiform activities comes out. If they do, then obviously I stay put. And some people, many of those patients don't remember the seizures because they were intubated or in non-clinical status epilepticus. They don't remember, so they usually want off the medications, but a select few patients remember the seizures, and they fear coming off a seizure med. So with a history of stroke or brain bleed, they are at elevated risk for seizure recurrence. Sometimes they opt and prefer to stay on at least a low dose seizure medication and not be in that situation again. And so I do take their personal preference in account too, but we do at all possible try, within I usually do the reassessment in 6 months or a year, an EEG, and then try to wean off if they're in that lower risk group.
I just want to add to.
What was that? Cave. CAVE. Thank you. Yes, it's the amnesia being put on the spot, but CAVE, it's the CAVE score. Yes, I would refer to that article. It's a great resource.
And I was just going to add, I think it's really important to get someone to a neurologist or an epileptologist as quickly as you can post. I'm working with the brain tumor group on this, because what they see is, they had this symptomatic seizure in the hospital. They got started on Keppra 750 twice a day, and they go home, and then they have a second seizure and panic and go to the ER and get readmitted. And so if you get them to an epilepsy specialist early, then we can help manage that in the outpatient side, give them rescue medicine to have for the generalized seizures, and talk to them about seizure safety and when you need to seek emergency care, because not every seizure needs to go to the ER, right? And so I think you're going to help your readmission rates if you do get them in to see someone quicker.
So I'll take an online question. There were two that were on a similar vein. I'm not sure who wants to answer it, but one was, if you're following, someone's on Lamictal and they're pregnant, we know that their level's going to drop. Do you have I think their concern was how much Lamictal can you give them each time, or do you have a protocol for this, or is it really, do you do a percentage based on the drop? How do you handle that?
Yeah, I think it's how significant the level drops and if they're having seizures. Typically, if I see a level drop, I might go up 50 milligrams and recheck a level, and then another 50, recheck a level. And it could get a little cumbersome for the patient. But I think, going up 100 is a little too much typically for side effect profile. So my rule is usually 50 at a time.
Yeah, I guess the other question I have is, if you go up to 100, do you increase your risk of a skin reaction?
Not typically, because we're not going higher than what they typically are. We're just trying to get their level back up to where, and once they clear the 1 month mark of the dermatologic reaction risk, your chances go much farther. It's not a high risk to get that reaction later down the road.
And then the other question was on the other end. So they deliver the baby, they're at a high dose now. How do you decrease it?
50 a day. I mean,
50
really,
every day?
Yeah, if they're at 800, and we usually, again, target a little bit higher dose than what they were on pre-pregnancy. But within a week, you should be close to pre-pregnancy dosing, or else they will hate you.
Yeah, they'll get the double vision dizziness.
And not able to hold their baby.
Okay.
Yeah. And another thing on levels is just to make sure, check the time that they were drawn, because a lot of times it was drawn at a peak level, so make sure it's a trough.
And if a drug has a free and a total, what do you check?
The older anti-seizure medicines often have a free, and I typically check both.
Okay.
a free and a total. I think the free is helpful in the side effect profile.
Okay. Payal?
Okay, so for Liz or Susie, going back to the folic acid, and I'm sorry if you mentioned this and I missed it, but if you're using an ASM for another indication, topiramate for migraine prevention, are you also, should I also be supplementing folic acid for these patients? Generally, we counsel our migraine patients to come off preconception, but that doesn't always happen.
Ooh, that's a good question.
I think the risk is when it's 200 or more. So if they're on a lower dose for migraines or something, I don't think there's as high of a risk, right? I think it's dose dependent for topiramate, from my understanding.
That's an interesting question. Is there any like guidelines in headache world about prescribing folic acid? No. It's interesting that we narrow it down on epilepsy, because I guess to your point, in epilepsy they tend to stay on it, but in headache world they if someone with a migraine, you can kind of opt to change, or maybe a little bit more easier, or get off of it before pregnancy. But in a lot of our patients, there's a lot of unplanned pregnancies. So I think based on the data we have in our field, it probably wouldn't be unreasonable to just give a little folic acid even at 1 milligram. I mean, especially topiramate makes me nervous just based on the information that we have about it. Although, you could argue that once they're pregnant, you could get them off. Like in epilepsy, we worry about breakthrough seizures, and in migraine, you could probably get them off a little bit easier. But usually by the time people find out that they're pregnant, they're already, how many weeks pregnant are they? So I don't know. That's an intriguing question, something that headache specialists should debate about. But I would kind of, just based on our experience, I would err on the side of just giving it, like at least one.
Thanks.
Yeah.
Thank you. So remember, out there we have errors of omission and errors of commission. And, I ask patients all the time when I see them that have had a seizure and they present to my clinic with a brain tumor, what were you told about the seizure for driving? Now, again, you never know how truthful they are, but the typical response is, nobody told me anything. I drove here today. So again, it is our responsibility to have these discussions, and it is inappropriate if we do not do it. So, again, someone may not be in a position where they're going to remember anything you told them when you initially see them, but you should tell them and you should document it as you go through. It is not adequate not to. So make sure we're doing that. The other thing I'll mention is that as a brain tumor person, I was part of a nationwide panel. We published a paper a couple years ago where we looked at the use of anticonvulsant medication in newly diagnosed brain tumor patients that have never had a seizure. And the bottom line is there is not clear evidence of a long-term prophylactic benefit in individuals to be placed on anti-seizure medicine that have never had a seizure. So if you want to do that, you should have a rationale and document why that is. If somebody comes to see you on anti-seizure medicine a week after surgery, never had a seizure, the guideline recommendation would be to wean off of the medication. Okay? I'm sorry, I'm just an old guy. I'm on the podium, I talk.
My question is in regards to Epidiolex, CBD, or medical marijuana. Usually we can get authorization for pediatric patients with Lennox-Gastaut for Epidiolex. But it's very hard to get authorization for other seizure types or refractory seizures. And a lot of the families may, and especially the teenagers now, have easy access to get medical marijuana cards. How are you approaching these patients in your practice?
That's a fantastic
That's
question.
a really good question.
Well, we'll be here for a while.
Yeah. The way that we have to address that at Cleveland Clinic is that we are not.
We order in food. No.
Yeah. We we do not write for medical marijuana cards. I discussed that medical marijuana is not FDA regulated, so I can't comment on that because I have had people go to other states. When Colorado was the first to approve, I had a family move out there, and they were on Depakote, and he was on like 4 anti-seizure meds. He ended up in the hospital in status because the medical marijuana he was getting, Charlotte's Web, messed up his levels, and they called us and said, "We're in status. What do we do?" And we're like, "You're in Colorado. I don't know. Ask the neurologist. You did something. We can't help you with this." I think Epidiolex is at least FDA approved. It's only approved for Lennox-Gastaut, Dravet syndrome, and newest on the list is tuberous sclerosis. So you can get it approved for those off that label. You know, if it's not on that, it's very hard to get approved, and usually like $30,000 a year for patients. So it's not feasible. I think that it really, studies have shown, I think that it really does just help those specific, you know, epilepsy syndromes. So I have not seen a huge benefit in clinical practice either way. I don't think it hurts like alcohol use, lowers the seizure threshold. So I at least counsel that you know, because you don't know what you're getting when you go to the dispensary. You really don't know what's in that. So I can't comment on that.
Yeah,
Yeah.
I'm the same. Yeah, so the question here was how often do we see kidney stones and topiramate? And the secondary question was, what do you suggest doing? So I think it's pretty infrequent overall. I think we're biased because
3 to 4%.
3 to 4%. Okay, good. So yeah, and based on just kind of practicing, it seems pretty infrequent, 3 to 4%. So we try to avoid prescribing it in people with a history of kidney stones. I've been in situations, you know, then when someone does get a kidney stone and they're on topiramate or zonisamide, that can increase the risk as well. Then you have to have the conversation with them on what we're going to do with the medication. So usually we try to switch off of it at that point, but we have had some patients come in and say, oh my gosh, I've had such good seizure control on this medication, I can't switch, I can't. So they know of the risk of the kidney stone. Maybe it wasn't a bad kidney stone. Maybe it was one that passed spontaneously and they opt to stay on the topiramate or zonisamide. That's their choice. They're knowledgeable of it. But then you have some patients that need a surgery from the kidney stone and a stent, and they had bacteremia and it's a mess. So in those patients, I really try to get them off of the medication as a first.
Yeah, and you can obviously drinking. I always counsel when they start the medication, drinking 6 to 8 cups of water a day is necessary to keep that medicine flushing through the system. And they should avoid foods high in oxalates because that's what helps to form those kidney stones. So avoid that. Because if someone develops a kidney stone and then they're like, or they had one 5 years ago and they're like, but I love this medicine. I'm like, well, you got to avoid these foods then. And some of them are like potatoes and spinach, and it's hard, right? And then also a little bit of lemon in water can be really helpful.
Mm-hmm. It's also, if they do have a stone, it's good to capture it and then check what it's made of. Is it calcium phosphate or oxalate? Can help a little bit with that. So we'll take one online, and then we can only take one more from here. People will be available, and then we'll take a break. So the question, I think, had to do with the patient you presented, and that is, if someone's on Depakote and they stop it early in their pregnancy, does that affect autism risk down the line, or we don't know?
Yeah, that's a very good question, and I do not know. I don't know how far into pregnancy the valproate would affect those risks, and I'm not sure we have a clear study on that as well. And that's actually a question that I had, because when thinking about trying to transition to a different medication in the middle of pregnancy, you know, we just don't have that data. We don't know if it's just early exposure or throughout the whole pregnancy, if it matters. So great question.
All right, one last question.
Yeah, hi. Could you give some pearls or some advice on how to broach discussing with a young woman who could potentially become pregnant? What is the first thing you might say to make it less of an awkward conversation?
Absolutely. We can both chime in here, but the way I approach it is I kind of make it a lighthearted conversation, because some of these women are so young and they're they're, getting ready for college, or, they're just so young and they don't even have a boyfriend or anything or significant other. So I usually approach it by saying, there's some certain things that you should know about the treatment that you're taking. And then I bring up, some medications do affect pregnancy, and that's an important conversation being a woman. I don't know, I mentioned this earlier, but I say, I don't know your stance on pregnancy in the future. I don't know if it's in your near future or not. Maybe not, but I need you to know this information, and I need you to carry it forward, no matter if you're seeing me in the future or someone else. And so I kind of just approach it in a lighthearted conversation. Or sometimes I ask, what do you know about the medication you're on? And I get their perspective first, because sometimes they've already been given the speech, and then I don't have to repeat it, which is nice. What do you know about the folic acid? What do you know about this medication and taking it through pregnancy? So those are kind of some strategies that I use. And I say, look, I'll give you my spiel, book it until later. If you don't, you got to hear it, and then I will be done. So I approach it in that manner.
Yeah, no, I agree. I think, I think it's important for every female to know this information, and that's why we talk about it. And they kind of start glazing over after a little bit. Yeah. They're not planning it, and you're like, okay, we'll talk about this again. And we do bring it up. We try to bring it up yearly, really. And what do you remember about pregnancy? Mm-hmm. And we always stress, if you are planning pregnancy, you need to tell us. So, if you decide to plan a pregnancy within the next year, please call the office so we can counsel you, because then we really, get that level and hone in.
We have to stop, so we're going to take a break. We're over time. If you have questions there around, you can ask them during the break, but we'll let everybody out. We'll be back in 20 minutes. We'll do some Jeopardy, and then there's the non-CME. Thank you.